individual awarding proposals go and what they want to do present.
I've been very familiar with the Anchor Institution work, and especially in Chicago, Rush has now targeted a 50% reduction in mortality differential between the Chicago Loop and West Chicago, not in 3 years, but in 5 or 6, and it's going to be pretty exciting to see if they can get there. The other question, I guess I am blindsiding everybody, but any way to get more than $1.25 million into this? Is there any other pot of money that could be tapped? Because this is really important stuff.
I'm going to look to David to answer
that. This is the amount of resources that the HBC has available. This is essentially the end of our trust fund money that was our initial source of assessment money at the beginning when the HBC was established. So this brings our kind of the pool that we have that the legislature gave us at the outset. This is it. However, I do think a couple of things we're thinking about. One, are there opportunities, depending on the applicants and the people involved, what types of resources they are going to be able to put to the table. We also do know that there are a lot of other private funders and foundations that are also really interested in the space. I think we would love to think about an opportunity to maybe leverage some of our public dollars with private philanthropy dollars to be able to expand this even more. And again, I think if we can show some success here and build a model, I mean, that is something that I would certainly bring back to the legislature and say, we built something really special here, because I think this is an area and a policy focus that has a lot of consensus among all of the different political and policy stakeholders. So we're thinking about it, Commissioner, and want to maximize our benefit.
And just personally, I actually think it's really exciting to do this as a state agency, because most of the organizations we talk to are funded by philanthropy. And I think being able to demonstrate that we can put state dollars behind this and bring some flexibility to this kind of very innovative work, I think will be a really, really good learning. So with that, let me flip to, honestly, what I think is...
I'm sorry, I know we're short on time, but one other thought here, and I should get something. I was on the commission that the Attorney General appointed to look at committee benefits requirements, which we issued a report last summer. I can't remember when we reported out. I think there's still an opportunity here to invite, on a voluntary basis, healthcare providers in the Commonwealth to take some of the committee benefit dollars and define it in this way. And I would urge conversation. And the DON both, yes.
I'm only to say I think that's exactly what we're hoping that this policy alignment work group, that is kind of one of the action strategies, is going to think about and talk about. Recognizing that there may be things that are not achievable in the short term, but let's open everything up, put things on the table, and see what we can come up with, where we can go.
Any other thoughts or questions? Okay. I'm going to put a stake in the ground and say this might be the most important slide in this deck. If we had to cut everything else, I might leave this, because I think if there has been one lesson we learned in conversations internally, externally, everywhere we've gone, it's this absolute necessity of being very, very clear about what we mean when we say moving upstream. Because you say that to 10 different people and you get 10 different sort of assumptions about what it means. Ironically, I think part of that is a result of the fact that there actually has been some very positive progress within healthcare institutions in terms of acknowledging and dealing with individual health-related social needs. Doing the work, as Fran mentioned, in some of the chart awardee hospitals, of identifying non-medical needs and connecting individual patients with resources. And in some cases, that has actually broadened to defined patient populations. That's really good. It's really important. We don't want it to stop, and it's not mass up. Okay. So what distinguishes mass up from all of this very good work of addressing health-related social needs is the need to get at these underlying causes of poor health outcomes and disparities. And essentially, as one of our colleagues who we interviewed over the summer put it, decrease the need to do so much of that downstream and upstream work. So, the kind of activities we think about when we talk about moving upstream, it's really understanding local community needs and health equity priorities, both through the existing sources of data and, to Catherine's point, through authentic engagement. The second is really inventorying current health system and community work, stuff that's already going on, and using the opportunity to coordinate and align that and get that sort of a 2 + 2 + 2 = 10 power, as opposed to all of these things happening disparately. And finally, to really work hard to develop upstream goals, strategies, and tactics. So let's talk about how that translates into specific requirements that we are proposing for the investment program. The first three are all around local focus. We have to see proposals that focus on a community, one or more specific zip codes. So not a patient population, not a panel, but a geography. The second is access to community level data with a demonstrated understanding of relevant social determinants of health and health inequities in that community. I mean, what you're doing has to be informed by the need, not by some other mechanism for just deciding you want to work on it. And then the third is, as we said, so many times, but I'll say again, a clear strategy for authentic community engagement. This is not, we're going to go do one focus group. This is really developing the mechanisms to consistently hear from the community. The second sort of core domain requirement is upstream vision. So we've talked a little bit about proposals to deepen current work or initiate new work that goes farther upstream. I think to the earlier conversation, defining expected results, including health and health equity improvements, and process measures that reflect, meaningful change management that will allow the work to sustain, which brings us to the third point, which is sustainability. How does this work continue when the grant ends? And finally, partnership. In order to be eligible to participate, you have to come to the table with at least one healthcare provider organization and at least one community benefit organization. It would be nice if there were more, but this is the minimum. And I do want to point out that in this context, we will give priority to provider organizations that are or participate in HPC certified ACOs. We see real benefit to that strategic alignment, and we wanted to err on the side of caution and cast as wide a net as we could. The partnership also has to propose a collaborative governance and decision-making structure that equitably empowers provider organizations. And to your point earlier, as we think about the parameters for reviewing these proposals, we'll have to define exactly what that means and the principles that we'll be using to assess it. And finally, we will be looking for proposals that articulate clear roles for each partner organization in the operating partnership, and in terms of how it's going to operate and how they're going to execute on their goals. And again, that gets to the question of, what's the day-to-day structure to ensure that somebody gets up every single day worrying about how to make this initiative go forward. Any thoughts or additions or comments?
I've had some very, very positive experience with consumer advisory boards. And I wonder if that might be a concept that you would include, that in addition to another healthcare organization, a CEO, that they actually establish a consumer advisory board. And that consumer advisory board would fairly reflect the diversity and characteristics of the population and their catchment.
Yeah, that's an interesting idea, and if I'm understanding it correctly, it's kind of inviting an intermediary with the ability to aggregate and consistently generate new insights about community needs as opposed to going direct. Am I understanding that correctly?
That's been my experience, tapping into the consumers of the services and inviting them to participate in conversations about what works, what doesn't work, what they'd like to see, what gets in their way. Oftentimes what gets in people's way are things that we don't necessarily think about. It's not on our radar screen.
Right.
And yet, once they say it, it's like,
How did I miss that?
how did I miss that? So it's an opportunity to also build faith in the community. Consumer Advisory Board, you listen to them, you engage with them, you ask them meaningful questions and take their advice and comments to heart and build it into your program.
That's a great idea. Any other thoughts or comments? Okay, with that, I'm gonna turn it over to Catherine to tell us what the next few months look like.
So really briefly on next steps, we are going to offer another broad opportunity for public input on this program through a request for information process. We have a document drafted and plan to post tomorrow on the state's procurement platform called Combis. This RFI, we will also seek to disseminate it widely through all of our channels and our partner agencies in this. I'm sure will support us in that. I want to highlight we are interested in input from the full range of interested stakeholders in this program, including healthcare organizations for sure, but also community-based organizations and social and human services providers, local government entities, other philanthropies or others who are involved in this work. I think our ears are wide open and we want to hear a diversity of perspectives. The timeline will be fairly quick, so act fast and please submit your responses to us by October 25th. We have a range of questions in the RFI to prompt thinking, but we're also interested in any and all other ideas that people have to support the work. And this is all on our way to issuing a request for proposals for the grant program before the end of the calendar year. And our timeline, therefore, takes us, as I mentioned, into December for this release process. We're targeting the month of February for the proposals to come back to us for review. Our goal is to review them sort of in the month of March and then come to the HBC board at I think what is the April 1st board meeting to present our recommendations for the awardees for the investment program.
Will you be looking for responses from private vendors? Don mentioned Rush in Chicago. I know that they're contracting with vendors to help deliver services in the underserved areas.
I would imagine that could be another valuable source of input, yes.
One of the harder to think how you do it is international comparisons, because there isn't any country that I'm involved in that isn't struggling with this, and there's some really, really good models developed outside the U.S. So it might be a good feeder of ideas. So we can talk about that. OECD and the World Health Organization are both terrific resources in this field.
Really helpful.
Can you send us copies of the RFI?
Thank you very much.
We're done?
Thank you.